Okay, so let's welcome Dr. Jodie Pritchard. She is presenting today on hyperthermia. So I will let you get started.
Perfect. Thanks very much. Let me just share my screen here. Okay. Are you guys able to see the full slides, not presenter view?
We are seeing presenter view here.
Okay. Sorry, give me 1 second. I got a new monitor and now it's never works as well as you think it will. That's also going to be. Sorry, 1 second. I see that's still for presenter view for you guys. Is that better full view for you now?
So we can see the bottom slide, like we can see your slides at the bottom and at the side.
Okay.
Yeah. I don't know if someone from the practice team who uses this regularly, do you remember how to?
I think after so much pandemic teaching, we'd got it down, but unfortunately I got a new monitor. So
are you using 2 screens or 1?
I have 2. That's probably which usually works, but sorry, give me 1 second.
You just have to share your second screen once you, yeah.
Yeah, that's what I was sharing, and then it was presenter view. So let me just try once more. That's going to be presenter view for you guys, because for some reason these have switched. Not sure.
There we go. We just,
Okay,
but we see your icons at the bottom, but that's close enough.
Okay. Perfect. I tried to turn off all my apps that notify, so hopefully it won't be noisy. Sorry about that. All right, quick introduction. So I'm Jodie. I'm an emergency medicine physician at Queen's University in Kingston. I started off in Kingston about, just over 1.5 years ago now, after graduating from medical school and residency training at McMaster. Before doing my emergency physician training, I was actually a paramedic. I worked for Orange for quite a few years, so covered a lot of the kind of north area. So probably, I'm sure, have met some of you at some point. I worked out of Timmins and then moved down to Toronto and did a bit of international work before going back to school. Like I said, I'm currently an emergency physician in Kingston. Had the pleasure of coming up to Moose Factory, I guess about a month ago now, and hoping to go back up again to do some work. And I'm also a transport medicine physician with Orange. A typical disclosure slide. I have nothing financial or otherwise to disclose for this. So just wanted to start off with a little bit of a an introduction to elevated temperature or hypothermia. Essentially, there's 2 main reasons. So fever is when the body raises the set point beyond our normal daily variation. So we all have like time of day variations. If you're doing a night shift and you're freezing at 3 o'clock, that tends to be why. And so essentially, the fever itself is, if you think of a thermostat, you've turned the thermostat up from 21 degrees to 28 degrees. Hyperthermia, on the other hand, is that thermostat is set at its normal set point, but the body temperature is elevated due to field thermoregulation. So either the body's producing too much heat or absorbing too much heat. or is not able to dissipate as much as it should. And so essentially this would be an example of, your thermostat at home is still set on 21 degrees, but your house is on fire. Sorry, and I forgot to say, I do have the chat open, so feel free to post in the chat, and please feel free to interrupt with any questions. This is meant to be informal and helpful for you. So. In terms of heat kind of gain and loss, so ways that we gain heat are base metabolic rate, exercise and exertion, radiant energy, so radiant energy from the sun, radiant heat. If you think of, standing on a hot black paved road in the middle of the summer, it's much warmer than if you were standing on grass. Ambient temperature as well as humidity. And lots of ways that we lose heat, we'll get into them in a little bit more detail, but radiation, convection, conduction, evaporation, and respiration. Typically for, the average person, we sweat about 1 liter an hour if we're like moving when it's cold. And that can double up to 2 liters in a hot environment. And once we are acclimatized to heat, you can actually sweat up to 3 liters. So you certainly can get hyponatremic if you are producing a lot of sweat, like typically over 5 liters a day. In hot weather, you need kind of 6 to 12 grams of sodium. A typical North American diet is 5 grams a day, which is more than we need for about the 2 to 4 grams if it's not super hot out. Women do produce heat and lose it more easily. And when we talk about acclimatization to heat, it's really the body adapts after about 7 to 14 days of daily exposure to heat. So if you go somewhere warm or it's a warm, summer day, it does take a few days for you to acclimatize. And basically when that happens, your body's kind of compensation mechanisms are that you sweat more easily, you lose more sweat, but you lower the sweat sodium so that you don't get hyponatremic. So again, just kind of going back to methods of heat acquisition, conduction is direct contact, convection is about kind of the flow, if you think of like boiling water. And radiation, a good example there of like warmth coming up from a fire, as well as like the sun rays on you, obviously you feel quite warm. In terms of losing heat, so there's a lot of similar mechanisms, evaporation, heat radiates out of you as well. Conduction, I think this is a pretty good example, like sitting on a cold rock on a cold day, you're going to get cold very quickly. And convection talks about the air moving. And so that's, you'll see that with wind chill essentially. So for thermoregulation, essentially, if we had no thermoregulation, our core temperature would increase by about 1 degree Celsius per hour. So essentially means that if you didn't have mechanisms for thermoregulation, you would die in 4 hours doing nothing and 20 to 30 minutes if you were working out. So this essentially is why we need functioning thermoregulation in order to survive. Just in terms of heat production, we typically produce about 100 kilocalories an hour. Dehydration affects how much heat we produce. So we produce an extra about 0.5 degree for every 1% of body mass that we lose when we're dehydrated. And obviously you can see activity really increases your heat production as well. We essentially have 3 kind of mechanisms of control. So the skin, it sweats and has blood flow, and your skin temperature is what determines if your body starts to shiver or to vasoconstrict. Our muscle mass, again, generates heat with activity, as well as with shivering. And central control, obviously your hypothalamic set point that controls your temperature there for your fever and stuff. So lots of risk factors and things to think of that can cause heat illness or make you more susceptible to heat illness. You'll see a lot of like chronic medical conditions on that list. A lot of medications can do it. So just things to think about. Medication certainly is such like psychiatric medications, anti-Parkinson's meds, sedatives, stimulants, and diuretics all affect your ability to retain and dissipate heat. Certainly older age is a risk factor. I think if most of the heat waves that kind of make the news, you'll see fairly higher rates of illness and death in older people. Really due to a lot of factors. They're more likely to have underlying medical illnesses. They often take medications that affect their ability to sweat. They may have like cognitive abilities that are different, and so not able to recognize that they're starting to feel sick or too hot. And certainly, like children, if they have decreased mobility, it would be harder for them to get into somewhere that's cool. They also hold more heat than younger people. They don't sweat as well, and they don't circulate blood as well, typically with heart disease or peripheral vascular disease. And they're also more prone to electrolyte imbalances. So lots of reasons why they're more prone to heat illness and why it's often more severe. Similarly with diabetic patients, they become dehydrated more quickly, especially if they're already hyperglycemic. There can be damage to blood vessels and nerves as a consequence of diabetes, and that can affect their ability to sweat. And also they're at higher risk of hypoglycemia in hot environments. And if they're like doing a lot of activity that's generating heat, the body's metabolism is higher, so it absorbs more insulin. Obesity is a factor. You produce a bit more heat when you're obese and dissipate heat less easily. And the other kind of one I'll mention on there is alcohol intoxication, like acutely. They're at higher risk for dehydration because you get the diuresis with it. And also, depending on your alcohol level, I guess, not as likely to recognize that you're starting to get sick. Any questions so far?
40 people, that's pretty good.
Okay. So we generally think of heat illness as being along a spectrum. Minor heat illness is things like heat rash, you can get edema, heat syncope, and heat cramps. Where we get to the more severe side, or middle, I guess we're talking about heat exhaustion. So kind of fatigue, headache, not as significantly elevated temperature as there is in heat stroke. Usually have sweating, orthostatic hypertension, things like that. And that's really due to volume depletion from our heat stress. And then heat stroke is on the kind of the more severe end, obviously. And that tends to be a higher temperature. You get CNS dysfunction, hot skin, tachycardic, and they may or may not be sweating. Again, this is a bit of a spectrum, so you will sometimes see overlap in the different illnesses. So heat stroke we define as a core body temperature over 40.5 degrees. There's CNS dysfunction. It can range from really mild, like behavioral changes, to severe, obviously, like seizure or coma. It also can be quite severe and end up in multi-organ dysfunction. You can get edema and hemorrhage of the GI tract, coagulopathy, electrolyte disturbances, lots of other consequences of that. And you can have permanent effects such as residual brain damage. Severe signs and symptoms are typically just due to the body trying to compensate with vasoconstriction, poor organ perfusion as a result, cell death, and there's also inflammatory processes from that. So looking at, the possible end organ effects would kind of determine if you have access to blood work, what you would do. So things you want to send off, just a general like CBC, electrolytes, extended lights if you have them, renal function, liver function, and like coagulation studies, just things to start looking to see if there's more serious signs. And really anything other than very mild heat stroke, which would be very like subtle neural changes, very mild vital sign changes, and should respond easily to treatment. If you have really anything other than very mild, they do need to be transferred to a higher level of care, because like we said, it could be quite severe multi-organ failure. So just a little, again, kind of summary of the heat stroke diagnosis. So core temperature greater than 40.5 degrees Celsius. CNS dysfunction, again, can be pretty subtle to quite obvious and severe. an exposure to heat stress. So whether that's an environmental, a metabolic, or toxin, and we'll get into that more in a few minutes. And then kind of signs of end organ issues, so elevated liver enzymes, that type of thing, multi-organ dysfunction, and hot skin. And you can or cannot have sweating. It's really not a diagnostic criteria. So heat stroke is often classified by this kind of classic description, although I will say there's a lot of overlap between the two. So classical heat stroke tends to be your older person in their house on a hot heat wave day. They tend to be older. They tend to have more comorbidities. They're usually sedentary at that time, often on many medications, again, as they're older. They may or may not have sweating, and they typically get less of the electrolyte disturbances, so the hypokalemia, the hypocalcemia, less often rhabdo, elevated lactate, renal failure. Versus exertional is your classic picture of a young person going out on a run on a really hot day. So again, tend to be younger, tend to be healthy. It's usually induced with exercise, often not on any medications, usually quite profound sweating, and more likely to get the electrolyte disturbances, rhabdomyolysis, and renal failure. Again, there's a lot of overlap between these, so it's certainly, like most things in medicine, it's not like black or white, one or the other. So essentially for heat stroke, what we want to do is we want to make sure we get a core temperature if possible. So rectal or esophageal temperature are the most accurate in terms of reflecting the true core temperature. Obviously not always available, but they are more accurate than either like a tympanic or axial temp. So things you want to do, obviously have them stop whatever activity induced it. You want to get them into a cool environment. Your standard approach to your ABCs and treatment of those. And then you want to work on cooling to less than 39. You don't have to get them quickly back to 36, but under 39. A couple of ways you can do cooling. So passive, certainly, bringing them into the shade if they're outside, bringing them into like an air-conditioned environment. Conductive cold water immersion is actually the optimal cooling method. And the colder the water is, the faster your core temperature will cool. We talk about kind of immersing people in like a cold ice bath. Not feasible most places, but ice itself, I think we're always taught, ice packs to the groin, axilla, kind of good flow places. There's actually quite limited evidence on that, but again, if that's all you have available to you, that's very reasonable to do. Other things we talk about, so, trying to get evaporative heat loss, so removing blankets, clothing, you can douse them with water. You can facilitate convection with fans. If you think about, I think you guys recently had the chat on hypothermia. Essentially, you're trying to do the opposite of what you want to do to warm somebody up. Hydration is important to replace volume losses. Again, you produce more heat when you're dehydrated. IV fluids are ideal for that. If you don't have IV fluids, you can do PO treatment, obviously, as long as their GCS is appropriate. Things we might do in hospital, so again, rapid cooling. They may require intubation in order to cool them. IV fluids, a Foley just to monitor urine output, and you can get quite profound hypotension. And so once we replace volume, then they often require vasopressors. With hyperthermia, there's no role for like Tylenol, Advil, other antipyretics, because again, it's not that set point that has changed. It's the body's has lost its ability to regulate. Seizures and shivering can be treated with benzodiazepines. Again, both seizure activity and shivering generate heat themselves, so you want to avoid those. In areas with limited resources, don't have all of the fancy hospital equipment, things you can do. So try and get them into a cool environment. If you have air conditioning in the room that you're in, turn on the air conditioning and make it feel quite cold for you would help. If it's colder outside than in, opening windows, things like that. Can mist the patient like with water and turn on fans. This is always quoted in textbooks. I don't know what it's like where you work, but our infection control would throw like a hissy fit, and we don't even have access to fans. So it always sounds great in the textbook, but in real life, other things have changed that. Certainly cool IV fluids if you have them, or PO fluids. Keeping in mind that you don't have to actually necessarily put the saline bags in the fridge or anything. Room temperature is typically 21 degrees. So that's going to be much cooler than the patient who's over 40 degrees. So, ice packs we talked about. If you have actual ice and are able to just put it in baggies, that's actually more effective than those like cold packs. They tend to not get as cold, and they don't stay as cold for very long. So. And again, we talked about you can immerse patients in cold water, either cold bath or cold shower, if you happen to have that at your facility. Okay, hoping to make this a little bit more interactive so you don't just all have to listen to me. Things that you would think about differential diagnosis for heat stroke. Feel free if you want to pop it in the chat or just unmute yourself, and what would be your things on your differential to think about.
Toxins?
Yeah, perfect. Yeah, we've got two votes for toxin. Sepsis, perfect. Yeah, perfect. There's a few coming up in the chat there. So toxins we talked about, sepsis or infections, serotonin syndromes. Yeah, perfect. So again, pretty broad differential. I tend to think of this as my hot and altered LOC differential. So things like intracranial hemorrhage, particularly hypothalamic hemorrhage, but you can get it with all severe head injuries, toxins and drugs. There's a huge list of those. Things in particular to think about. So like anticholinergic drugs, sympathomimetics, stimulants, so either in cold medication, it's in a lot of the pre-workout supplements. So that's one thing to ask about if somebody has been working out. Aspirin overdoses can do it. Alcohol withdrawal can do it. So lots of different drug-based ones. A seizure itself, just because you're generating heat. Things like malignant hyperthermia, again, usually have a story for having been to the OR, things like that. NMS and serotonin syndrome, like somebody mentioned, can certainly do it. Metabolic issues like thyroid storm in particular can. And then your infectious things to think about. So is it actually just a fever? Is it sepsis, encephalitis, meningitis? Okay. So I thought we'd talk a little bit about approach to kind of history and physical exam. You're obviously going to do your full standard past medical history, medication, social history, and physical exam for all patients that come in. But important to kind of pay particular attention to risk factors for heat illness or things that are signs and symptoms of heat illness. And going back to that differential list, right? Also thinking through things that would cause a, maybe an infectious process or something else that's on your differential for hyperthermia. So, past medical history, again, asking around those risk factors, including age, obesity, diabetes, peripheral vascular disease, social histories, or is there alcohol use? Are they in a warm environment and not, don't have enough income to, install a air conditioner, things like that. Smoking is one, obviously, for the peripheral vascular disease. Medications, we kind of touched on, there's a huge list of medications. So which of those could possibly cause heat illness? Vital signs. So again, always a reason to do a full set of vitals on everybody that comes in. So you want to get a temperature, a glucose, their GCS status, and consider an ECG if you have access to it. So physical exam and review of symptoms. Again, you're going to do like a full thorough head to toe. Looking for, altered neuroscience, signs of trauma. Again, going through that whole differential diagnosis. Is there, chest pain? Is there shortness of breath? Did they have a new murmur? Again, thinking infectious, cardiac. PE can also cause elevated temperature. Abdominal pain, so nausea, vomiting, diarrhea, poor urine output, reasons for kind of fluid loss and dehydration, and skin, obviously looking for like burns and rashes. Things that would kind of be a red flag and a reason to kind of do more thorough workup and more investigations. So obviously altered level of consciousness, abnormal vital signs, chest pain, you just start thinking about a differential. Shortness of breath, same with that. Is it an infectious cause? Is it a cardiac cause? Renal function and electrolyte abnormalities. If you have the ability to kind of do some testing for that, kind of clues I find for electrolyte abnormalities before you have blood work back. So is there ECG changes? Do they complain of muscle cramping, weakness? Seizures can do it. If in your kind of story you get from the patient, has there been poor intake of anything other than water? Do they have a lot of losses from sweating? Things like that would put them at higher risk for electrolyte abnormalities. Pause here for a second. Any questions or anything that wasn't clear? Please feel free to jump in. Okay. I thought we'd go through a couple of cases. And again, happy if you just jump in whenever you have a question or you have the answer. So case number one, there's a healthy 20-year-old comes to see you after his first day at work, working on a construction site in the middle of a heat wave. He complains of tons of sweating from the heat, and he's suddenly got a very severe pain in his left calf. What would be your diagnosis or your differential diagnosis? Do you have any thoughts? We'll go through this one. And I have to say it is kind of the wrong season to be doing this talk. So apologize for that. It was just one of the ones that came up that was requested. It's certainly probably your hypothermia lecture was much more relevant because I'm sure like we do, you guys have snow. So but things to think about for this. So again, lots of sweating, suddenly have a spasm in the calf or other places. Typically that's heat cramps, and it's really just related to sodium deficiency, either from hypotonic, so like water fluid intake, or heavy sweating. Typically you see it, lots of sweating during activity. They've been drinking things like just water to replace their sweat and their thirst. Typically is the most worked muscles that get cramps, and it's usually after you stop activity. Generally, treatment for this is just mild, and so you're doing oral rehydration solutions. There's tons of different ones in the market. It really doesn't matter which one you use. There's like hydrolyte tabs. You can get little sachets of powder that you mix in with a drink. You can make your own if you Google it. The WHO has a recipe online, and it's really just water, sugar, and salt in set combinations. Things like Gatorade or other sports drinks all have lots of sodium in them. And really should be able to treat these patients as an outpatient with just mild rehydration when they come in, unless there's other complicating factors, in which case they may need IV and further workup. Perfect. Sorry, I saw someone posted that in there. Yes, DVT and dehydration, excellent, excellent differentials. Okay, for the second one, you're working as a medical staff at a local marathon. It's a warm day, it's about 25 degrees out and quite humid. You're stationed at the finish line as the medical responder. You see a runner kind of slowly stumbling towards you and then crawls across the finish line. He makes it over the finish line to your area and you go to assess him. Obviously, you're going to do your full basic assessment, but key things that you find: he's got a temperature of 39.5, his heart rate's 134, his glucose is 4.5. He's sweating quite heavily, and he vomits. What would be your diagnosis and your differential? And feel free to unmute or throw something up in the chat. Yeah, so heat exhaustion versus heat stroke versus rhabdo. Yeah, perfect. So yeah, this one, more a case of heat exhaustion, but great differentials to keep in mind. Again, everything's a spectrum, right? So for heat exhaustion, you really get a lot of like dehydration, fatigue, headache, malaise, muscle cramping, nausea, vomiting. You can have syncope. The important thing to kind of think of is like, think of your differential diagnosis like you guys talked about, and make sure that there's not some other cause for this. There's essentially two types of heat exhaustion. So you often get like water depletion with inadequate fluid replacement for your losses. And this can progress to heat stroke. So that's why we see all of these things are really on a bit of a spectrum. You can also have heat exhaustion from just salt loss. So really you're just sweating a lot, replacing it again with the hypotonic fluids. The kind of key for this is you should have either a normal temperature or under 40. Again, over 40.5, we're talking about heat stroke. Should have a normal mental status, can certainly have tachycardia, sweating, orthostatic hypotension just with the dehydration. Kind of red flags that I would start to be worried about if you can't replace their fluid volume, they have ongoing nausea, vomiting, diarrhea, things like that. And so you can't just replace their fluids with PO or even IV fluid if they have a lot of ongoing, losses of water from nausea, vomiting, diarrhea. Recurrent syncope. So if then they syncopize once when they're out in the heat, that's one thing. If it's, recurrent or prolonged, then you want to start thinking about your differential diagnosis for syncope. So is there like severe dehydration? Is there cardiac problems? Is there electrolyte disturbances, neuro, things like that? Orthostatic hypotension, certainly a lot of people get in the heat. If it doesn't respond to either IV fluids or if they're able to take PO fluids, then again, want to start thinking about a differential diagnosis. Is there something more serious going on? And same with tachycardia. So, tachycardia with either elevated temperature, fever, all of those things we're used to being pretty normal. But if it's, not responding to getting them into a cool environment, not responding to fluids, then, starting to think about, is there some more worrisome cause? Any questions with that one? And so essentially for heat exhaustion, we're talking about treatment. So really, again, you want to get everybody into a cool environment. You want to replace their fluids. You don't want them to go back out and start playing soccer or whatever they were doing that caused them to get heat exhaustion. So some rest. If you have access to it, you can certainly, again, things are a little bit along the spectrum. If you're worried that they're a bit more severe, maybe getting into heat stroke. If you have the ability to, you can set off blood work, looking at their electrolytes, liver and renal function. Anybody who has like serious electrolyte abnormalities should get admitted. Things to think about is, do they have comorbidities that put them at higher risk of not being able to compensate, possibly progressing to heat stroke, then would be also admitted. But healthy young patients who respond quickly to treatment can just be treated as an outpatient. Okay, any questions with any of that so far? So case number 3. Based on a real case, sort of. So it's suddenly a warm 25-degree day in Moose Factory Hospital. The heat was on because it's steam heat and it's either on or off. And it was cold 3 days ago, so the heat's on. Everyone is complaining about the temperature in the hospital. It's far too hot. You are part of the team that's looking after COVID positive patients, so you're in full PPE. You are in the room, you hear a crash and you turn around and find one of the nurses on the floor. What's your diagnosis and what's your differential diagnosis? And feel free to chat, or if you're in a super noisy environment, to put in the chat. Perfect. So we got syncope or vagal. Yeah. Perfect. I'm sure lots of us have either had this or seen this. Yeah, perfect. Differential, heat exhaustion, heat stroke. Yeah, exactly. I didn't give you a full set of vitals, so perfect. In syncope. Yeah, awesome. Heat syncope we tend to see with prolonged standing, more common in older adults, although I will say that orthostatic changes and syncope are often quite common in kind of younger females who tend not to have a very high blood pressure to start off with. Essentially, it's a temporary loss of consciousness, same as other types of syncope due to low cerebral perfusion pressure. So, it's hot out, you get increased peripheral vascular pooling, like in the lower extremities, a bit of dehydration. You just get poor venous return, which affects your cerebral perfusion pressure. And essentially fainting is your body's way of telling you that you need to lay down flat to get some more blood flow up to the brain. So similar to all of the other kind of benign syncopes like orthostatic. Things you want to do to treatment, so supine positioning, again, just restoring that blood flow, getting them out of a hot environment. And, like a few of you mentioned in there, right, there's a differential diagnosis for this. So want to rule out other causes of syncope. You guys talked about heat exhaustion, heat stroke. Is it hypoglycemia? Did they have an arrhythmia? Did they hurt themselves from the fall? Those types of things. So. All right, so case number 4, a 35-year-old presents to see you on a hot summer's day complaining of a rash. The rash is really itchy. It's a little bit of like vesicular red spots, and there's no sweating over the rash. Any thoughts on the diagnosis for this and your differential for this?
Heat rash.
Yep. Perfect. I don't know if anybody's had this, but it is incredibly itchy, which is why they call it prickly heat rash or heat rash. Essentially, it's just due to the blocked sweat glands. And like I said, it's often very itchy. Things to think about, other causes of a vesicular rash, although don't necessarily look exactly the same, chickenpox, shingles, monkeypox, all those things can kind of give you more of a vesicular rash, tend to be not as red though as this. Obviously, you can get a superimposed infection, just like all of your other rashes if people are scratching at it. Basic treatment for this, chlorhexidine, you can get lotion or creams, and you can get like 1% salicylic acid lotion just to help kind of unblock the sweat glands. So this also will just go away with being out in the heat less and some time, but it is quite itchy for most people.
How do you deal with folks that are allergic to the sun, like photosensitivity?
I mean, there's a few underlying things that some people can have, like lupus, things like that can cause people. Some people are just really allergic to the sun. Unfortunately, most of the like treatment is really just about like light, loose clothing, wearing hats, umbrellas, that kind of thing, and like just really reducing the amount of skin exposure. Which nobody likes to hear if it's finally a nice warm day and they want to get out in the sun, but that's really the best treatment for it. Perfect. Any other questions? All right, so case number 5. A 50-year-old woman comes to see you at the clinic. She was spending a week in Toronto during a heat wave and just got home. She complains her ankles and feet have been swollen for the last 3 days. What's your diagnosis and what would you think about for your differential diagnosis? Yeah, heat edema, perfect. What would you think about for differential? I'm sure lots of you guys have seen other reasons for swollen feet and ankles. CHF, yeah, perfect. So again, heat edema is pretty classic. Essentially, you get interstitial fluid accumulation, independent extremities, so typically your feet. Again, just similar to other causes of edema, but a hydrostatic pressure, you have vascular leak, and vasodilation in the skin, and so things pool independent areas. I think you guys brought up, yeah, perfect, renal disease, CHF. So, kind of need to think about, is it something else? Because those would require a bit more workup. Certainly if there's associated chest pain, shortness of breath on exertion, shouldn't be unilateral if it's heat edema, and shouldn't be really a significant size difference, although you can always have a little bit, but needs to start thinking, if it's unilateral, like, is it a DVT? And obviously those kind of differential diagnosis, if you were worried, would warrant like further investigation and workup for that. Treatment really is, cooler environment, limb elevation. You can do compression stockings, and it really should improve in a couple of days with that cool environment, and either elevation or compression. And similar to peripheral edema from CHF or other causes, can actually be quite painful. So especially if it's a rapid accumulation. All right, case number 6. So 26-year-old female comes to see you in clinic with painful skin. She was outside yesterday in shorts and a tank top because it was a really nice warm day, although it was quite overcast. What would be your diagnosis for this? Anybody have a guess, or anyone seen, I'm sure, thermal burn? Yeah. So this is kind of your kind of classic sunburn. Whether we tan or burn easily really just is partially affected by the amount of melanin in your skin. Everybody can burn kind of regardless of how much melanin they have. And whether it's tanning or burning, they are actually both signs of actual like cellular damage at the skin level. You can definitely burn on an overcast day. About 80% of the UV radiation does go through clouds. And this is often when people get burnt, because if it's a really hot, bright sunshine day, they would think about putting on sunscreen or staying out of the sun. And when it's overcast, people often don't think about it as much. Again, so it's essentially like an inflammatory reaction to UV radiation damage, accelerates skin aging. It's the leading cause of cancer. So this is one of these reasons this is important for all of us to think about, but 5 or more sunburns doubles your risk of melanoma. And even one kind of blistering sunburn in childhood or adolescence doubles your risk of melanoma. So things you can do, obviously, if you're outside and notice that it's happening, you can go in a lake or pool, river, whatever to cool off, but then you want to get out of the sun. If you're at home, cool bath, cool showers, things like that. Ideal to moisturize when the skin is still damp because it absorbs more. You'll often see like sunburn treatment creams that have either aloe vera or soy in, just to help with some more moisture retention. If it's really painful, you could apply some kind of topical hydrocortisone cream. The one caution they have is really not to use anything with like a cane in the end, so like benzocaine treatment. They help, like similar to lidocaine, that you mix in with like a pink lady. They help with some numbing, but they're often quite irritative to the skin. And lots of people have allergic reactions to them, which is just going to compound the problem if you're already sunburned. So really just best to stay away from those. If there's no contraindications for the patient taking NSAIDs, they're a good anti-inflammatory and pain relief. If there is contraindications, then just Tylenol for pain is fine. Things you want to do, increase your fluid intake, burn skin, particularly if it peels or gets blisters, you lose more water through there. In terms of blisters, so if you have blisters, it's essentially a second-degree burn. Don't want to pop them, and the skin may peel, which is pretty common after. The biggest thing is really protecting yourself and telling them to protect themselves from future burns. And really should be wearing sunscreen kind of anytime you're out in the sun. Yeah, aloe vera gel is fine as well. Lots of people, there's all kinds of topical burn treatments and sunburn treatments. So aloe vera is good. I know people that actually have an aloe vera plant, and that would be fine too. Big thing, so babies under 6 months should never be exposed to the sun for more than a few minutes, obviously. Having them in carriers, covering them with umbrellas, things like that, if you're outside in the sun. And then really everybody over 6 months should be protecting themselves from the sun with kind of daily broad spectrum sunscreen, protective clothing, like you can get lots of loose, thin clothing for the heat. And obviously the radiation can also from the sun can affect your eyes, so UV blocking sunglasses. Things that would make you worried if they had burns that they might need some more care. So if there's a significant percentage of their body surface with blisters, just because again, the risk of dehydration, infants for sure, kind of that 6-month age, the sunburn need good monitoring in terms of their dehydration or losses if they have blistered skin. So that would be, infants would be somebody I would send out for higher level of care for sure. Any other questions? I'm just making sure there's none in the chat, but feel free to throw any in. Yeah, so in terms of kind of who this applies to, like really everybody, in North America, we tend to really only see sunburns most commonly, in the summer, just because it's nice weather and people are getting out and getting exposed more and have more skin exposed. If we're bundled up in the winter, we tend not to have much skin exposure, but you definitely see this in people that are out, in the winter, outside. We just it tends to be facial because really not much else is exposed to the sun. And the risk of burn, like I said, it's a bit of a spectrum. The paler you are, the faster you'll burn. But everybody can burn. You can certainly burn like with black skin as well, just depending on the amount of exposure. And the risk of skin cancer, again, a little bit higher if you're very pale, fair-skinned, because you burn easier, but everyone is vulnerable to this for sure. So hopefully this doesn't cut off for you, but just kind of a general review. So again, if you're thinking about heat illness, it really divides into the minor versus the major ones, like we saw on that spectrum. So is there signs or symptoms of central nervous system changes? If yes, you always want to make sure you get a temperature. If their temperature is over 40, then starting to think of treating for heat stroke. So again, your ABCs, trying to rapidly cool them, starting IV fluids if you can, and arranging for transports to hospital. If they have some signs and symptoms of altered CNS, their temperature isn't 40 or above, then really starting to think about your differential diagnosis. So is it hypoglycemia? Is it a seizure? Is it hyponatremia, which can do seizures as well? Is there a CNS disease? Is there an infection, endocrine issue, things like that that we talked about, and your whole kind of drug toxin differential. If you're thinking signs or symptoms of heat illness, kind of going down the right side of that pathway. So again, there's no signs of central nervous system, then you're thinking more of the mild heat illnesses, heat cramps, heat exhaustion, heat syncope. Treatment for these, when it's mild, is usually just about oral rehydration, cooling them off to under 39. You can certainly give like ORS fluids, which contain salt, even simple things like a bag of like salty chips, that type of thing. I find when I've worked in hot environments, I always get to a point after a couple of days of being really hot and sweaty. I just get a craving for like a bag of Lay's salty chips, and that usually makes me feel better. So again, just replacing those salt losses when you have higher sweat loss. And then, kind of just monitoring with the treatment that you've given. So the oral rehydration, some salts. Are symptoms getting better? That's great. Kind of just need to keep them in a cool environment. Kind of do some education for people so they're just not getting heat illness again. And again, talking about not returning to activity. So, you just rehydrated somebody, ideal for them to not go out and do whatever exertional exercise was causing them to get hot in the first place. And then if symptoms kind of are worsening or haven't improved with the cooling and oral rehydration. So then again, want to consider alternative diagnosis, work on cooling them a bit faster if you're able to, and thinking about getting them transported somewhere for a bit more evaluation. Perfect. Any questions? Anybody have any good stories of things you've seen? Happy to, I'm just gonna read this one. What form of fluids are ideal for heat stroke? So if you have access to IV fluids, normal saline would be fine. And again, even at room temperature, it's going to be cooler than the patient, so that would be good. If the patient doesn't have severe altered CNS where they would be safe to drink and you don't have IV fluids, you can really just start off with water for a bit of hydration, and ORS, like the rehydration solutions, if you have it, just because they're going to help replace your sodium losses as well. I'm going to read the other question that's in here. So the question about fever that isn't related to hyperthermia. I've heard mixed things about treating fever versus letting the fever run its course. What are the recommendations? Age or temperature? Thresholds to prevent febrile seizure. So kind of an interesting topic, especially right now. I'm not sure how bad it is where you guys are, but we're having a lot of febrile illness in kids, which I know you guys are as well. And we have like essentially no supply of children's dosing of Advil and Tylenol. Yeah, exactly. So I've seen hundreds of kids over the last week. Basically, a lot of that is just with not a lot of access to Tylenol and ibuprofen, and understandably very frustrated parents with their miserable kids with their fever. There's really, fever is your body's kind of natural way of trying to fight off viruses and bacteria. We tell parents really the only reason that we're treating fever is just because kids, like all of us, are miserable when they have a fever. And so really they tend to, they don't want to drink, they don't want to eat, they don't want to sleep, they're super fussy, they're miserable. And so if you can get that fever down with Tylenol or Advil, the kids just feel better. There's really no evidence for like a lowering fever otherwise. It's really just about like everyone is just happier if the kids feel better and their fever is lower. And yeah, so in terms of febrile seizures, last I looked at the evidence was really, it's more so about the rapid elevation, more so than numbers. Parents often get very obsessed about numbers. There's not a lot of evidence that, 38.5, 39, 39.5, there's really no big difference in that. Again, fever is just kind of a sign of fighting off illness. And really, there's not good evidence for treating fever to prevent recurrence of febrile seizures. again, you're just trying to make sure that, there's no more serious cause of the fever. If it's an underlying viral illness, you're going to really just treating the fever for the kids to feel better. I don't know if that answered your question, but hopefully. Any other questions? Anybody have any good cases of hyperthermia they've seen? I can tell you, having done a fair bit of global health work, I've had heat syncope. So one of those, again, right, people that are just prone to it anyways. And just until you get that acclimatization level, you really, it's hard to keep up on your fluid losses if you're somewhere that's, over 40 degrees and super humid. So my big pearls for that is really just keep up on his fluids as much as possible and don't spend for a long time standing. Perfect. Any other questions? The number of days it takes you to acclimatize. It's about like 1 to 2 weeks, essentially. So that's why, if you ever travel anywhere, go down south in the winter or something, you really feel the effects of the heat more easily. If you happen to be somewhere for longer than a week or two, then by then you've started to acclimatize. So you're just better able to cope with the heat. It's why often, people in the summer, if it's, gets hot, the first week, if you try and do activity or running outside, things like that, you really notice it. And then you do eventually adapt to it essentially and don't really notice it as much. So. Perfect. Any other questions? Anything can help you with? It looks like the evaluation link is up in the chat there. This is my first presentation with you guys, so happy for any feedback for sure. And if there's any other topics that you'd like to include, I know they always ask you for those, but I'm certainly happy to try and include some more emerge based topics if that's of interest to people.
Great. Thank you so much. We appreciate the time, and thank you everybody for taking the time this morning to come out. Have a great day.
Thanks, everybody.